Hello and welcome. Let's talk about hypoglycemic agents. Now, diabetes mellitus may be type 1, type 2, type 3 or type 4. Type 1 includes insulin dependent diabetes mellitus, type 2 includes non-insulin dependent diabetes mellitus, type 3 includes non-pancreatic disease, drug therapy and genetic defects, and type 4 includes gestational diabetes. Now, hypoglycemic drugs. It may be parenteral, which includes insulin, or oral, which includes insulin secretagogue like sulfonylureas, meglitidenide, and alpha-phenylalanine derivatives. Others include biguanide like metformin, thiazolidines like pioglitazone, rosiglitazone, and alpha-glucosidase inhibitors like acarbose, miglitol, and pralinetide, exenatide, and sitagliptin, which is dipeptidyl peptidase 4 inhibitor. Now, insulin. Let's talk about insulin, its history and chemistry. Insula means island, and insulin is the first protein proved to have a hormone action. The chemistry is that it is a small protein with molecular weight 5808. It contains 51 amino acids arranged in 2 chains. The changes in the amino acid in both chains are the species differences. This is a picture showing the molecular formula or molecular structure of insulin. Different amino acids are seen. Now, synthesis. Insulin is synthesized as preproinsulin and then becomes proinsulin and then hydrolyzed into C-peptide and insulin, which is 51 amino acid protein, and the 4 amino acids are cleaved off to circulation. Now, storage. It is stored within the granules of the beta cells of the pancreas with insulin and C-peptide. It is stored in the form of the crystal, and the entire human pancreas contains 8 mg of insulin. Now, species of insulin. Human insulin, bovine insulin, porcine insulin, recombinant DNA technology with entheogenicity, the bovine, porcine and human. Now, release of insulin. Insulin released from the pancreatic beta cells, and the glucose enters into B cells and mediated to ATP, and there is increased ATP level which closes ATP sensitive potassium channel, thereby decreasing the outflow of the potassium efflux and depolarization of the B cells and opening of the voltage gated calcium channel, which causes intracellular calcium, which releases insulin. Now, the factors influencing increased insulin secretion. Glucose is the principal factor. Mannose and fructose, amino acid like leucine and arginine, vagal activity, intestinal hormones like GIP, GLP-1, gastrin, cholecystokinin, secretin, BIP, enteroglucagon, and drugs like sulfonylureas. Now, pharmacokinetics. When given orally, it is degraded by the proteolytic enzymes because insulin is protein in nature. So, it is given parenterally, usually by subcutaneous method. It is not bound to plasma protein and the circulates free in blood as monomer, and the serum half-life is 3 to 5 minutes. It is metabolized by 2 main organs, liver and kidney. The endogenous insulin by kidney 40% and liver 60%, and exogenous insulin by kidney 60% and liver 40%. The insulin degraded by insulinase to degraded products, and then these are again metabolized by proteolytic enzymes. The insulinase by glutathione insulin trans dehydrogenase. Now, this is a picture showing different organs acting with relation to the insulin. Now, mechanism of action of insulin. The insulin binds to alpha subunit of the insulin receptor present in the cell membrane, and it causes confrontational changes and causes phosphorylation and autophosphorylation of the tyrosine kinase of the cytoplasmic beta subunit, and it is the first protein to be phosphorylated. And there is insulin receptor 1 and insulin receptor 6 phosphorylated tyrosine kinase. These are the substrate providing docking site for the other signaling protein, and first activates phosphatidyl inositol 3 kinase and then activates GTP binding, leading to protein RAS complex and MAP kinase. The translocation of the glucose transporter causes increase in the glucose uptake, increased glyconeogenesis, increased glycolysis, reduced glycogenolysis, reduced neoglucogenesis, so reduced blood glucose level, increased lipogenesis, reduced lipolysis, increased photosynthesis, increased cell growth, and others. The factors increasing the number and affinity is insulin receptor. Starvation, excess growth hormone, exposure to reduced insulin. Factors reducing the number of the insulin receptor, obesity and excess glucocorticoid. Now, Pharmacological effects. It is a anabolic hormone which controls intermediary metabolism. The effects are traditionally classified into three based on their kinetics. First, immediate effects are rapid effects. Phosphorylation and dephosphorylation of the enzymes leading to increased transport of the glucose and amino acid and activation of the ion transport system. The intermediate effects includes activation of the glycogen synthesis and glycolytic enzymes, inhibition of the phosphorylase and gluconeogenic enzymes, stimulation of the protein synthesis, and inhibition of the protein degradation. The delayed or long-term effects includes increased mRNA for lipogenic and other enzymes and stimulation of the cell proliferation and differentiation. Effects on liver includes increased hepatic glycolysis, reduced glycogenolysis and gluconeogenesis, increased glucose uptake, glycogenolysis and reduced ketogenesis, increased TG synthesis, increased VLDL, reduced CAMP, and increased uptake of the potassium by liver. On muscle, increased amino acid transport, increased protein synthesis, increased ribosomal protein synthesis, increased glucose transport, increased glycogen synthesis, and increased glycogenesis. There is induction of the glycogen synthesis in the inhibition of the phosphorylase. Now, effects on adipose tissue. It activates hormone-sensitive lipoprotein lipids and hydrolyzes lipoproteins to triglyceride. It inhibits lipoprotein lipase and causes increase in the TG synthesis, reduced free fatty acid, increased triglyceride storage into the adipocyte, and reduced lipolytic action. Effects on the glucose transporter. Glucose transporter 1, 2, 3, 4, 5 are stored within the intercellular storage vesicles in cytoplasm. When insulin combined with the insulin receptor, GLUT is inserted into the cell membrane and glucose is entered into the cell by small or simple diffusion. Now, effects on carbohydrate metabolism. Increased glucose uptake, glycogenosis, glycogenolysis, glycolysis, glycerosynthesis, and reduced gluconeogenesis. On protein metabolism, reduced protein metabolism and increased amino acid uptake and protein synthesis. On fat metabolism, increased lipogenesis, increased free fatty acid synthesis, triglyceride synthesis, and reduced lipolysis. Now, relation to potassium and calcium. Insulin causes increased potassium entry into the cell by sodium potassium ATPase and reduces extracellular potassium, leading to hypokalemia. Insulin increases the uptake of the calcium into cell, so hypercalcemia causes increase in the insulin. Effects on cell proliferation. It stimulates cell proliferation and so helps in the somatic growth, cellular growth, and development. Now, these are the different preparations of the insulin with their onset and duration and the drugs. Very short acting is insulin lispro, insulin aspart, insulin glucosilin, and inhaled insulin. Short acting includes regular or soluble crystalline zinc insulin. Intermediate acting includes neutral potamine hexadrone or isophene insulin. Long acting includes ultralente insulin glargine and insulin detemir. Mixture of the insulin may be neutral potamine hexadrone and regular, neutral potamine lispro and insulin prispro, and neutral potamine lispro and insulin aspart. All insulin are available in the strength of the 100 units per milliliter and available in premixed formulation. Insulin delivery system. It may be portable pen injectors, continuous subcutaneous insulin infusion devices, and inhalation of the insulin. Clinical uses includes type 1 diabetes mellitus, juvenile diabetes, diabetic ketoacidosis, diabetes with pregnancy, type 2 diabetes with complications, failure of the oral hypoglycemic agents in type 2 diabetes, and emergency treatment of the hyperkalemia. Now, adverse effects includes hypoglycemia or hypoglycemic shock, which is the most common effect. It may be due to delay in the taking meal or less carbohydrate intake or more insulin intake or unusual physical exercise. Symptoms include tachycardia, palpitations, sweating, tremulousness, nausea, hungry, may progress to confusion, convulsion, and unconsciousness. The treatment is, if patient is conscious, prompt intake of the oral carbohydrate, oral juice, dextrose tab, glucose gel, or any sugar-containing beverage. If unconscious, 50% glucose, IV infusion should be given over 2 to 3 minutes, and injection glucagon 1 mg subcutaneous or intramuscular should be given, and injection adrenaline should be given. If insulin allergy is seen, then type 1 hypersensitivity is rare, and the type 2, 3, 4 develops with the non-insulin protein contaminants. Insulin resistance is very rare and said to be resistant when insulin intake more than 200 units and produces no effects. The most patients develop low titer of the IgG antibody. Lipodystrophy at injection site may be seen. Weight gain is a common side effect, and hypokalemia may be seen. Now, oral hypoglycemic agents. These include insulin secretagogue like sulfonylureas, which includes acetohexamide, tolbutamide, chlorpropamide, glyburide, glibenclamide, and meglitide like repaglinide, and alpha-phenylalanine derivatives like nataglinide, and others including biguanide like metformin, acarbose, exenatide, and sitagliptin. Now, this is a picture showing mechanism of action of sulfonylurea. Now, these sulfonylurea combine with the sulfonylurea receptor associated with beta cell ATP sensitive potassium channel and causes depolarization of the beta cell and opens voltage gated calcium channel, thereby increases calcium influx and causes increase in the release of the insulin from pancreatic beta cells and inhibits glucagon secretion and increase the insulin receptor sensitivity. Now, first generation in comparison to second generation sulfonylureas. These are less potent, less hypoglycemia, especially in elderly patient, more adverse effect, less expensive, less used, and no caution in the patient with cardiovascular disease or in elderly patient, and more drug interaction. Pharmacokinetics. These are well absorbed when given orally and all bind strongly to plasma protein. Duration of action. Glyburide for 10 hours, glipizide 7 hours, tolbutamide 6 to 10 hours, glimepiride is long acting and once daily dosing. Most sulfonylureas cross placental barrier. These are contraindicated in pregnancy. These are used for type 2 diabetes and type 2 diabetes resistant to insulin. Adverse effects include hypoglycemia, weight gain, secondary failure, increased risk of jaundice and antidiuretic effects, muscle weakness, headache, teratogenicity. Now, biguanides. These are the euglycemic agents and insulin sparing agents. There is no weight gain, no hypoglycemia, and most often prescribed for patients whose hypoglycemia is due to ineffective insulin action, and there is reduced risk of the microvascular as well as microvascular disease, and preferred in obese patient. The drugs includes metformin, which is the only biguanide drug available. The mechanism of action is not clearly identified, but there may be increased tissue sensitivity to insulin, increased peripheral glucose uptake, reduced hepatic and renal gluconeogenesis, reduced absorption of the glucose from gut with increased conversion of the glucose to lactate by enterocyte, and reduced plasma glucagon level. Now, pharmacokinetics is that it is well absorbed when given orally, not metabolized, and causes lactic acidosis. Advantages include this is euglycemic. It not depends upon the functioning of the beta cells of the pancreas, and there is reduced postprandial blood glucose level but does not cause hypoglycemia, does not increase body weight. The disadvantage is that it causes lactic acidosis. Clinical uses includes obese patient with non-insulin dependent diabetes mellitus, new onset of the type 2 diabetes mellitus in middle age, patient with refractory obesity which hypoglycemia is due to insulin resistance syndrome, and diabetes mellitus where monotherapy is not adequate and used with sulfonylureas or thiazolidines. Adverse effects includes GI toxicity like anorexia, nausea, vomiting, diarrhea, and lactic acidosis, and reduced absorption of vitamin B12. Contraindications include patient with renal disease, alcoholism, hepatic disease, and chronic cardiopulmonary disease, where there is a risk of lactic acidosis. Now, thiazolidines. These are euglycemic drugs including rosaglitazone and pioglitazone. The mechanism of action. These bind to nuclear peroxisome proliferator activating receptor, many present in the muscle, fat, and liver, and modulates the transcription of insulin genes and thereby causes increased glucose uptake in the adipose tissue and other tissues, increased sensitization of the tissue to insulin, so enhancing the action of the endogenous insulin, increased number of the insulin receptor, and reduced hepatic neoglucogenesis. Redistribute the body fat, leading to reduced triglyceride and increased HDL. Also have significant effects on the vascular endothelium, the immune system, and the ovaries and tumor cells. Pharmacokinetics includes slow onset of the action, and the duration of the action is over weeks or even months. Drug interaction may be seen with pioglitazone, with no drug interaction with rosiglitazone. Clinical uses include type 2 diabetes, combination with the biguanide, sulfonylurea, or insulin, and patient with the most severe insulin resistance can be indicated. Adverse effects includes increase in the body weight, total body fat increment, fluid retention causing mild anemia and peripheral edema, increased risks of heart failure, hepatotoxicity, and risks of the pregnancy may be increased. Anovulated women may resume ovulation, so patient with taking OCP should be precautioned. Contraindication includes pregnancy and significant liver disease. Ripaglinide, there is a very fast onset of the action, and the duration of the action is 5 to 8 hours and should be taken just before meal. The mechanism of the action. The drug binds to potassium channel of the beta cell and modulates beta cell insulin release by regulating potassium efflux. Clinical uses includes diabetes mellitus, monotherapy or with biguanide, type 2 diabetes in patient with sulfur allergy, and adverse effects includes hypoglycemia. Now, alpha glucosidase inhibitors. These includes acarbose and miglytol. Mechanism of action. These drugs are competitive inhibitors of alpha glucosidase and decreases the postprandial digestion and absorption of the starch and disaccharides. The uses include type 2 diabetes as monotherapy and type 2 diabetes combined. Now, adverse effects includes flatulence, diarrhea, abdominal pain due to undigested carbohydrate, increased hepatic enzymes, and hypoglycemia. Contraindication includes inflammatory bowel syndrome, hepatic disease, and renal impairment. Now, combination therapy. To manage the long-term treatment of the type 2 diabetes, multiple medication may be indicated. Initially biguanide, then second-line therapy includes insulin or second agent with biguanide, or second agents includes insulin secretagogue and others. Third-line therapy may be biguanide with multiple other drugs. Fourth-line therapy may be intensified insulin management with or without a biguanide or others. End of the topic.